Good morning, and I'm thrilled to be the opening speaker for the last session focused on NHSN's AUR module. And today I'll be discussing antibiotic stewardship and optimizing antibiotic use in an inpatient setting. Next slide. We all know that antibiotics are frequently used in hospitals. A recent CDC analysis illustrated that 1 in 2 patients received antibiotics for at least one day during an average hospital stay. And this is also consistent with CDC's Emerging Infection Program Prevalence Survey that found that approximately half of patients were receiving an antibiotic on a survey day. Next slide. It's also estimated that 30% of antibiotic use is unnecessary or inappropriate in the hospital setting. And examples of unnecessary antibiotic use are potentially that antibiotic didn't even need to be given, include treatment of asymptomatic bacteria, non-infectious lower respiratory tract conditions, or contaminated blood cultures. And then examples of inappropriate include when you potentially will be using excessive broad spectrum therapy for empiric therapy when it's really not appropriate, or not de-escalating or narrowing spectrum of therapy when you have culture data, or prolonged duration of therapy. And these poor prescribing practices are placing patients at unnecessary risk for antibiotic-resistant infections, C. difficile infections, allergic reactions, and other adverse events. Next slide. The CDC released Antibiotic Use in the United States, Progress and Opportunities in the summer of 2017, and it summarizes the current status of human antibiotic in the U.S. across the spectrum of care. And it provides examples of CDC's approach to improving antibiotic use in the acute care, long-term, and outpatient setting. And it divides it into the main categories of data for action, implementation, innovation, and education. And I thought that would be a great framework for this lecture. And for the remaining of the talk, I'll provide some examples of these approaches focused on the hospital setting and specifically the AU option. I just want to also highlight that we are in the process of updating this document for 2018, and we tentatively plan to release later in the spring. Next slide. The first category, data for action. Next slide. Antibiotic use measurement has long been a challenge for hospital stewardship programs. The questions typically are what to measure and how to do it. Internal measures, so if a facility is just internally measuring it for their own use to assess progress, are important, and it's a bit easier because they can just use their own internal methodology standard. And comparative measures are strongly desired, but are much harder to develop in terms of having standard methodology and the infrastructure and the technology. Next slide. The NHSN AU option provides opportunity for facilities and stewards to track and report their antibiotic use. The specific objective of the AU option is to measure antibiotic use to provide risk-adjusted inter- and intra-facility comparisons. Next slide. And the CDC developed a benchmarking measure for antibiotic use called the Standardized Antimicrobial Administration Ratio. And this is really most likely why the facilities are particularly interested in submitting to AU, and because they can receive the benchmarking measure for AU. The SAAR is similar in principle to the standardized infection ratio, and that the SAAR expresses the observed antibiotic use compared to predicted. And the CDC had worked with many partners to develop the SAAR measure and try to make it most useful for stewardship. And we originally created the SAAR based on 2014 data, and then most recently it has been updated with 2017 data. Next slide. And Wendy and Aaron are going to provide much more details of AU and the SAAR, but I thought just for a broad context, we developed the SAAR for different patient populations, adults and peds and certain ICU and non-ICU wards. And then we also developed the SAARs for different group of antimicrobials. And we use the groupings because classically there's similar ages within a category that may vary based on formulary decisions at the hospitals. And we didn't want formulary decisions or shortage of certain agents to impact the SAAR categories. And here are the SAAR categories for the 2017 SAARs. And this is for adults and pediatrics, but the specific agents that can be included for adult and pediatrics vary. And so understanding which agents is best to look at the protocol to really know what agents are in each category. But as a broad overview, one category is agents mainly used for hospital onset infections, and the example there would be piperacillin tazobactam. Agents mainly used for community-acquired infections, with an example would be ceftriaxone. Agents mainly for resistant gram-positive infections would be classically vanco. Narrow-spectrum beta-lactam agents could include nafcillin, oxacillin. And then for the peds-only SAARs, there's a category of azithromycin only, and the pediatric stewardship community felt that this was a high-value target for the pediatrics. And then we recently added a antifungal category, and we included agents such as fluconazole or the echinocannins that are mainly used for invasive candidiasis. We don't know the indication, but we just use this for naming the categories. And then we also added a category called antibacterial agents posing for the highest risk of CDI infection, and that includes the third and fourth generation cephalosporins, and as well as the fluoroquinolones and the clindamycin. And this might be a great opportunity for infection preventionists using the TAP strategy to collaborate with the antimicrobial stewards submitting to AU to evaluate potential opportunities for CDI reduction. And then we have an all antibacterial agent category as well. Next slide. For the role of the SAARs, the experts agree that the benchmark measures are extremely helpful in driving hospital improvements, and it can provide a broader context to internal measures. What if your antibiotic use goes down by 5% per year, but you find yourself twice as high as other similar hospitals? And so the SAAR data can quickly help you identify locations in the hospital and agents where stewardship programs can focus on. Next slide. And this is an example of a SAAR analysis exported to Excel. And on the y-axis, you have the SAAR value, and then the SAAR groupings on the x-axis. And the ATI that's the category, for example, with pip/tazo, and the CO is the category with ceftriaxone as an example. MRSA would be the category with vancomycin, and the narrow spectrum, an example would be the nafcillin, oxacillin, and then our all bucket. And if you advance the slide, if you're the stewardship team looking at your data, you can see that your community onset SAARs are higher in both your ICU and wards compared to the other SAAR categories. And this can provide an opportunity for you to further evaluate the drugs specifically within this categories to determine if there's opportunities to improve use. And facilities often will conduct a medication use evaluation, or will talk to the physicians and pharmacists that really know the prescribing practices in those specific wards, and then they can determine if there's opportunities to develop such as a treatment guideline for CAP or UTIs, or to really educate on duration of therapy, to then you really use this data for action. Next slide. But it's really important to keep in mind that the SAAR only directs stewardship efforts to location and antibiotics where use appears to deviate from predicted. So we cannot say that what is appropriate or inappropriate. It's just that we can tell you where use appears to deviate from predicted. And so high use may be perfectly justified based on your patient population as well as resistant rates. And low use does not necessarily mean inappropriate either, because potentially the low use is related to other factors and might even be harming patients. And so once again, it's not assessing appropriate or inappropriate use, but just guiding where use appears to deviate from predicted. Next slide. The CDC and the Pew Charitable Trust partnered with stewardship experts to design an assessment tool that can assist in the exploration of high SAAR values, or if you're not submitting the AU, other measures of high use. And the tool identifies high yield opportunities to improve use based on past experience. And so this is really a tool to be using SAAR to inform investigations and interventions. Next slide. If you start at the top, in our example, we'll pretend that we have a high SAAR value, and then your general assessments. Many of these different categories aren't applicable to data within the SAARs, but if you look at the two outside boxes, the search for specific agents driving overall high use, if you have a high SAAR, you can drill down to see what agents are contributing to the predominant use of within that SAAR category. And then you can also discuss antibiotic use in high use locations. An example with that would be if your SAARs are highest in your surgical ICUs, then that could potentially target discussions with the surgeons and the team in the ICUs to determine if there's opportunities to improve use. And typically, stewards, particularly the pharmacists, may conduct more intensive evaluations through a medication use evaluation, and then they can use this information to really understand why these drugs are being used in terms of empiric treatment for which specific infections, if there were missed opportunities for de-escalating, or was there missed opportunities for using shorter duration of therapy. And then based on their evaluations of more detailed reviews, then they can conduct stewardship actions such as providing feedback to the medical surgical teams and education, as well as even creating an intervention such as a treatment guideline or other mechanisms to improve use. Next slide. We often get the question of more specifically how facilities are using AU, and because the previous algorithm is more broad. And so we just launched in January 2019 what we're calling the NHSN AU case examples, and this is available on our NHSN AUR website, and it provides a real-world experience of a community hospital using SAARs to reduce fluoroquinolone use. And it's about a page, and it details their analysis of their SAARs, the approach that they took when they identified that the fluoroquinolone use was high, and then what they did from intervention was improving their, implementing treatment guidelines, as well as addressing duration of therapy, and then tracking their SAARs over time. And we plan to provide additional examples in the upcoming months. And so for facilities that are new to submitting and need some real-world examples of applying SAARs, this is a great tool for you. Next slide. I just also want to indicate that we are developing SAARs for neonatal stewardship or newborn stewardship. Currently, our pediatric SAARs do not include the neonatal patient location wards. And you can see by this pie chart that the breakdown of antibiotics is very different in the in the neonatal population, and not over half is attributed to ampicillin and gentamicin. Thus, we've been working with experts in neonatology and infectious diseases through the Vermont Oxford Network to develop neonatal SAAR categories. And most of you also know that we just added NHSN survey questions focused on neonatal. And we did this to capture facility level information that we could potentially use in the predictive modeling for the neonatal SAARs. And we hope that we can launch the neonatal SAARs in the upcoming year or two. Next slide. Implementation, next slide. We released the CDC core elements for hospital antibiotic stewardship programs in January 2014, and most of you are familiar with the leadership commitment, accountability, drug expertise, action to improve use, tracking, reporting, and education. Next slide. And we know that classically physicians and pharmacists are leaders or co-leaders of the stewardship program, but I want to highlight that many of you in the audience are infection preventionists and nursing, and you can have an incredible contribution to the stewardship team as well. And based on all your training and expertise for an infection preventionist, you have such experience with risk assessment and prevention planning skills and can facilitate collecting and analyzing antibiotic-related data. For nursing, reviewing medication is, of course, part of their routine duties, and they can contribute through promoting discussions of antibiotic treatment, indication, and duration. And so if you're not involved in your stewardship team, it'd be a great opportunity to go back to your facility and become part of the multidisciplinary team. Next slide. We track the uptake of facilities meeting all 7 core elements through the NHSN annual hospital survey. You can see here in 2014, we had 41% of facilities that self-reported an uptake of all 7 core elements, and that has been increasing over time. In January 2017, that's when the Joint Commission standard for stewardship became effective, and we anticipate that the percent will continue to increase over time. Next slide. For facilities that need help with implementing core elements or potentially having more robust core elements, a great resource is the NQF Hospital Antibiotic Stewardship Playbook that outlines specific actions that have been taken by other hospitals to implement the CDC core elements, and it also addresses barriers and solutions, and this was released in May 2015. Next slide. And when we evaluate the uptake of all 7 core elements by facility demographic, and this is based on the 2017 data, you can see that the critical access hospitals and facilities with bed size less than 50, as well as non-teaching facilities, had a lower percent of uptake of all 7 core elements compared to their counterparts of a general acute care hospital or facilities with greater than 200 beds and major teaching hospitals. Next slide. And to address this, we worked in implementing, we worked with the Federal Office of Rural Health Policy and the American Hospital Association and Pew Charitable Trust to launch what we call the Implementing Core Elements in Small and Critical Access Hospitals, and this was launched in the summer of 2017. And what this really is it's recommendations from small and critical access hospitals to small and critical access hospitals, because we know that they have very different infrastructure and staffing and resources. And so this document really places stewardship in the context of their infrastructure, resources, and staffing. And so if you are at a smaller critical access hospital and not familiar with this document, I highly encourage you to review it and see if any of this could be meaningful for your stewardship program. Next slide. We also want to improve the measurement of implementation of hospital stewardship programs, and the NHSN Annual Facility Survey stewardship questions present an opportunity to advance our understanding of program implementation. And now that the majority of hospitals have the basic core elements, we revised the survey to try to go deeper, and we asked more details on program structure and support and what specific actions and practices are hospitals implementing. And we definitely received the input from the stewardship community to ensure that we had meaningful questions. And we ended up having a required section and an optional section, and we of course would love if everyone could also submit to the optional section so we have more robust data that we can use in the future. Next slide. Ultimately, improving antibiotic use comes down to implementing interventions that will improve prescribing. And the goal of the stewardship program is to create an environment where improvement interventions will be most successful. Next slide. And some of the key moments for stewardship to act are patients with C. difficile, patients with positive blood cultures, patients being given IV antibiotics at discharge, patients on unnecessarily duplicative therapy, patients being treated for CAP, UTI, and SSTI, and these are often the three most common infections seen in the hospital setting. And so stewards often will really focus on optimizing therapy for these three infections type. And then patients who've gotten 3 days of therapy is an opportunity to potentially de-escalate or further assess therapy when there's more information that the physicians and providers have available, as well as potentially culture data. Next slide. Innovation, we are working with several researchers in advancing the SAAR measure. Next slide. We are working with the Duke Antimicrobial Stewardship Outreach Network. They were awarded funding to enroll a group of hospitals in NHSN AU and then implement or expand their stewardship efforts. And the main question that we're interested in, does the AU rate and SAARs change in response to stewardship? And then we also funded the VA Salt Lake City to electronically assess appropriateness, and what we call this is electronic MUE, or the electronic medication use evaluation, and then correlate that with the SAARs across the VA facilities. Next slide. We often receive questions about the risk adjustment, and we funded Duke University to identify patient and facility level factors predictive of antibiotic use that could be used in risk adjustment strategies for benchmarking antibiotic use. And then lastly, we often realize that facilities are exporting their data to Excel to really have data visualization for their stewardship programs. And so we also funded Oregon State University and Oregon Health Science University in collaboration with Virginia Commonwealth University School of Pharmacy to advance data visualizations for AU and our SAARs. Next slide. And lastly, education, next slide. This is focused on just general stewardship, and I wanted to highlight that last year we released CDC training on antibiotic stewardship. It's mostly focused on antibiotic prescribing in the outpatient setting, but there is a section, the first section is an overview of antibiotic stewardship, and then it really focuses on many of infections seen in the outpatient setting, but then it wraps up with a 1-hour lecture on hospital and ED stewardship, as well as another hour on nursing homes. So this is a great resource for complementary CE for a variety of healthcare professionals if you want to learn more for stewardship, or potentially getting your other colleagues involved, as well as trainees. Next slide. We held a webinar in November during Antibiotic Awareness Week that focused on engaging all hospital pharmacists in stewardship and identifying 5 ways or 5 scenarios that they can become more involved. And we will have this webinar available online in the spring of 2019. So keep a lookout for that. Next slide. I wanted everyone to mark your calendar that U.S. Antibiotic Awareness Week will be held November 18th to 24th in 2019, and this is a great opportunity for you to highlight the importance of appropriate use of antibiotics in your facility, as well as to get involved in some of the activities that we'll be hosting from a CDC perspective. And next slide. And this is just to remind you that we have many materials for healthcare providers and consumers on our Be Antibiotics Aware website, and we continue to add resources, so encourage you to look at this link and see if there's any resources that would be beneficial for your facility. Next slide. And this is just my conclusion that antibiotics are commonly used and misused in hospitals, and improving antibiotic use is an important public health priority and a healthcare quality and patient safety issue. And CDC's approach in improving antibiotic use focuses on data for action, implementation, innovation, and education. Next slide. And at this time, Emily, did we want to have time for questions or move on to the next presentation?
It looks like we have about 1 minute. So if one or two people in the room had any questions. All right, Melinda, it doesn't look like there are any questions in the room. Thank you so much for joining us today and kicking off the last day of the training.
Great. Well, thank you, everyone, and have safe travel.